Oh, hi. Good evening, everyone. It's evening here. Thank you, guys, Zazie and the crew. I really appreciate every information you have put out here. And I had actually sent this question before now by email. So I'm sorry I'm going to still sound like one peddling these conspiracy theories, but from what I've heard this evening, I still want to ask because I had to look up the meaning of a prophylaxis. And what I saw was treatment given or action taken to prevent disease. And listening to one of the doctors, he said that the drugs are still being studied and they're still undergoing regulatory, procedures. So there are no drugs yet. So I still wonder, how come no drugs to treat the COVID? And then we're supposed to be very comfortable with the vaccines that I'm told they've been studying, these technologies have been on hand to make the preparation of the vaccines, like available just like that. So forgive me, that's still my worry. And maybe because I'm a lawyer, I will still ask like a layperson. I always want answers. Why are the drugs taken? We have to wait for so long for the drug that can treat this. Yet the vaccines, we're supposed to just accept them in such short-term preparation. I don't know. Can anyone?
Let me.
Who wants to answer that first? Should I answer that first?
I was going to actually ask Keith.
Okay, Larry, go ahead, Larry.
I understand your concern. That means you don't have medicine and now want to prevent it even before the medicine occurs. So the reality about vaccines or about infections, it's the British that used to say that a penny of prevention is worth an ounce of cure. So from time immemorial, so from time immemorial, one of the things that has happened is that once something has already happened, it's sometimes hard to return back. We know from natural immunity, that means when I saw a patient like now 2 days ago who they thought had COVID. And when I went to see the patient, I said, oh, this patient does not have COVID. They said, how do I know? I said, yeah, he just had COVID a few months ago. So now that he's here now, no matter what your x-ray shows, he doesn't have COVID, so you can swab him. Of course he doesn't. That's because his natural immunity already is still working, preventing him from getting COVID again. So we know that. So you understand that as a lawyer, that we know that that's what will happen when your natural immunity has occurred. And if you measure, he has antibodies. So when the studies were conducted, they actually measured antibodies in those patients who got the vaccine, showing they were able to prevent. So that allows you to know clearly, without getting infection, it's easier for us to fix you after you have gotten antibodies. And in fact, convalescent plasma, which we use, are people who have already gotten the infection, got better, and then we give it to people so that they get better. The latest studies from that says that the ones that have a higher titer, that means the ones in which the antibodies is high, they actually do better when you give it to people that are sick and they get better without, in quote, a treatment like a Panadol or anything. So we already know that. So that's why vaccines are already easier to be used as a treatment before you actually get sick, kind of. But unfortunately, the virus, we just don't have a treatment because from time immemorial, we never really treated viruses. So when you had a cold, even in Nigeria, we didn't give you any medicine for the cold. We told you, just rest, get your body in, and that your immunity will take care of it. So that's how viruses have always been from time immemorial. So we're not saying anything new. There was really no treatment for viruses most of the time from 500 years ago. So it hasn't changed. So it's not as if there's any treatment for a virus now. So that's why the treatment end is like a, dead end. So why are you wasting so much time for something that is a dead end when we are not always so good in getting something that will treat the virus? Yes, we are lucky with things like HIV and hepatitis, but generally speaking, most viruses don't have a treatment. Our body immunity takes care of it. So that's why chasing a treatment is less likely to get a success than actually administering the vaccine. If that answers your question, I don't know.
So, that's quite interesting. I think you made a very good point, which is there are really no treatments per se for viruses, and you're right. Most times we just sit down and just recover. But I wanted to ask, I think her question, she mentioned prophylaxis, and I think Keith mentioned that in his talk. So Keith, I was wondering maybe you could kind of give a very high-level overview of what kind of treatments are available in terms of vaccines. I know we've got some antivirals, for example, in the market. What kinds of treatments and vaccines are available high level? And in this year, besides Pfizer and Moderna, what do we expect coming down the pike in terms of vaccines and or treatments?
So I'm not sure if Keith is still on. I don't see him.
Oh, he's not on? Okay.
I don't see him. Okay, but I'll tell you very briefly, maybe I'll answer that question since Keith is not on. We do have a monoclonal antibody in the United States. It's actually, I've given it to at least one of my patients, and I've given it to several people. And these are biologics that are built under the same principle of the fact that, somebody has a convalescent plasma and you're giving it back to them, giving it to a person who's sick to make them better. And I think in the recent data, Onime correct me, it was done in nursing homes in which they used these monoclonal antibodies and it was able to prevent people from developing frank infections. The study came out maybe yesterday or 2 days ago. So prophylactically, those particular things may actually work, where they give you an antibody, which is like giving tetanus toxoid when people have an infection. Let's say you injure yourself, then we give you the vaccine as well as the toxoid. So that principle may actually work if we develop things, but the cost of it is stratospheric. People in Nigeria or people in not even in Nigeria, even here in the United States, how many people are going to afford to be able to give people expensive monoclonal antibodies just to be able to treat that? So, but if you're in a Western world where your insurance is going to pay for it, fine. But even here, not everybody can afford it. So essentially, yes, there will be some prophylactic treatment, but there's really none that we have now. So, so at one point, remember, President Trump was saying he was taking hydroxychloroquine for prophylaxis. He still had COVID, at least based on what they told us. So it didn't work. So we would like to have something, but it's just not there. There are many things, if wishes were horses, we'll all have them. But they are not there, and they are not there. So the easy thing that's already there, let's do it. Let's get it done, and let's get it done quick.
Very quickly that history has taught us that the concept of herd immunity, where we started from, that there are two ways to get herd immunity: the infection or vaccination. Experiment for the infection, Spanish flu, 1918 pandemic. It went on for 3 years. About 50 to 100 million people died. In the US, almost 1 million people died. Eventually, the infection went away, AKA, we developed herd immunity. The other case in point, measles, polio. What happened with those? How did we end up eradicating those? We developed vaccines. So now, measles has become extinct in most places. Polio is extinct. Smallpox is extinct. How did they become extinct? It was through vaccination. So 2 ways to get to herd immunity: vaccines or infection. As to what is in the horizon here in the US, Johnson & Johnson, which is a vector vaccine very similar to the AstraZeneca one in the UK. I hear that the Johnson & Johnson one completed their enrollment for phase 3 trials late last month, I believe. So, I think November. So we're going to hear something later this month or early next month. I expect that within the next several weeks, we're going to probably have an EUA for Johnson & Johnson. There are about maybe 9 or so vaccines all over the world that are being in phase 3 trials or have already been approved by various countries. The 2 here, Pfizer, Moderna, you have the Gamaleya in Russia, you have the Oxford AstraZeneca in Britain, you have the CanSino in China, Johnson & Johnson coming up here in the US. You have Novavax. Yeah, you have the Sinopharm from the Chinese, which is an inactivated virus. You have the Bharat Biotech, which is in India. So there are a lot of vaccines in the horizon already in phase 3 trials. Some of them have been approved in various countries.
I think, in terms of the newer ones that are coming, one of the ones that's actually the most exciting is actually the Johnson & Johnson one.
Yes.
So that one is expected to be out maybe in the spring or first quarter 2021. And the beauty of the Johnson & Johnson vaccine, at least right now, it's a one-dose vaccine. So that's, you take the one dose, it's a adenovirus like the Oxford AstraZeneca vaccine, but it's a one-dose vaccine. And Johnson & Johnson has also promised to have 1 billion doses available, and they are also going to make their vaccine very affordable for developing countries. So they're going to almost give it away to developing countries. So that's that's very exciting that they get to do that. So I guess we'll just watch and see. So anyway, Keno, can you take us to the last, I think it's Martin.
Yes, we have one more person, Mr. Martin. Please go ahead with your question.
Thank you very much. And thanks to this panel for the grand education we've had regarding coronavirus. I want to speak about Nigeria, basically, given the fact that the vaccines aren't coming here soon, and given the fact that the numbers that we're seeing are not looking like they are an actual reflection of the written. This has been adduced primarily to lack of testing, and the cost of testing is so high. I know there are two primary ways of testing, the PCR and the lateral flow tests. And I'm wondering if currently in Nigeria, they use the PCR test as the primary means of testing, and the cost of that is quite exorbitant. So most people prefer to just write it out, given the fact that the same symptoms from our common infections of malaria, typhoid, and all that are replicated in COVID. So rather than test for COVID to be sure of what you are having, they just go to treat for malaria, typhoid, and then before they know, it becomes a bad case. So the question here is it possible to have, or is it low-cost testing means available? And then how can we use that as a means of prevention? And if that is not available, what are the best modes of prevention, given that we have a highly mobile population in Nigeria?
Okay, I'll answer the question. What you are doing is not unique to Nigeria, even though you suppose that's a Nigerian question. We have people here in Wall Street who want to run businesses and they are used to seeing each other. So they create what is called a COVID place, where somebody comes in with a testing kit and he swabs the nose and all swabs everybody who comes to that meeting. They get a test in about 15-30 minutes, and then people can join the meeting. But I can tell you, based on what we have already experienced here, is that many of the antigen testings have a lot of false negatives. I see it all the time. Today, I just saw a patient who had 3 so-called negative COVID. And when he came in, we put the swab all the way to the back. Of course, she was COVID positive because everything already added up to COVID. It was just that the testing was not done properly. So there's so much human dependence. So there's really no test per se that exists now that is so great. So the best test is the PCR test. It takes time. And in a population like Nigeria, if you're going to test lots of people, you're going to overwhelm the lab's testing ability. So in my opinion, my feeling is that, look, the solution is in front of us. Immunize people irrespective of what it is. When people are sick, you know what, assume based on clinical symptoms. Because once I had one of my colleagues from Nigeria send a thing to me on how to be able to identify people with COVID. And we just simply listed the things, the blood tests, the clinical symptoms, and that once they meet this criteria, they have COVID. So that removes the need for having to wait for the test. Unfortunately, it's still also commercial. First of all, I remember one of the owners of the private hospital in Lagos said they did not want anybody to know they had COVID in their hospital because nobody will come. There are other, and you can't have control over that. So the reporting of who has it, whether they don't even want you to know. So essentially, there's a stigma associated with it. And as long as the social stigma associated, just like when HIV was present when I first came to the United States in 1993, 94, this COVID also has that. And therefore, it's going to take much more than just getting these tools for you to test it and so on and so forth. It just states that, look, let's just get something that will just make it go away. And I think that the simple solution for the Nigerian government may be that. However, if you have money, you can. There are kits that you can use to test. You just have to remember that there's a limitation. That means the swabs have to be taken correctly, the test has to be run correctly, and then that person who you say is negative is truly negative. But those are the constraints that you will have. But they are available now. If you have the money and you have a big company, Martin, you can send for the test and you just screen everybody who comes into the office and test them right there, 30 minutes before they walk in. But again, I've already told you the limitations, but it's something that can be considered. But as a national thing, Nigeria builds stadiums, they are more interested in sport, they're not interested in healthcare. But when malaria is more important, which they could have dealt with, why are we going to talk about COVID? So I don't think it's going to be something that will happen that quickly in Nigeria.
So this is a very interesting point, Larry. Thank you for making it. It opens up so many other things. So I think I was telling Larry this when we were talking the other day, that at the end of December, I went to go get a COVID test. I went with 3 of my sons. And then about 2 weeks ago, I think I went to go get another COVID test because I was like, I was just feeling tired. So I just let me at least test myself. Well, I haven't gotten my results back. And I got a PCR test. And this is here in the US and in Georgia, just to show you just how overwhelmed our systems are. So I did it December 24th. What is it? January 23rd. I still don't have a result from both places I went to. But with regards to your question in terms of the test, so I hear what you're saying. And there are many issues, I think, that we can look at to address it. Can you get a simple test? Now, I know, especially in colleges, like my kids, for example, they get a COVID test every day. And what they do sometimes is a simple swab. But when they have to go to an event where there are many other students, they make them do a PCR test. So like Larry was trying to say, there are many of these tests that are available, but the reality is that they're not very sensitive. The best test is actually the PCR test, because it's the most sensitive test, but it's a very expensive test to be able to run. And it goes back to looking at us in Nigeria, like Larry said, what are our priorities? Do we make this level of investment so that when something like this happens, that's a public health issue, we can actually invest in providing testing on a national level that's expensive but can work, so that shows again the priority of the government. So I would say, Martin, no, that yes, there are tests that you can test, but they're not sensitive. We'll definitely not recommend that you make a diagnosis based on those tests. But if you were going to do one, go with the PCR test. And 3, yes, it's unfortunate if we don't have PCR testing, because in Nigeria, for example, our numbers may be low because we're not testing as much. That could, and we have a lot of other conditions that may mimic COVID, right? So those are just my thoughts with regards to it. There are many ways to skin it. And I just want to take this time to really thank everyone for spending all this time. I had no idea that we would all be here for this long, but hopefully you found this session informative. I'd like to thank the doctors, Dr. Larry Hassan, Dr. Linus Anuku, Dr. Ade Onime, and also Dr. Keith Robinson for their time. in spending with it. I think Keno is recording this, and hopefully we'll make the recording available at some time. And if you do have any more questions that have not been answered, you can feel free to reach out to me or any one of us, and we can try to see if we can get those answered for you.